when we look at the echo itself in pericardial diseases, so what is the utility in terms of where it stands vis-a-vis the other imaging modalities? So when it comes to the technical aspects in terms of the availability, cost, and the safety and the repeated, we can do it anytime, anywhere, repeatedly. So that is where echo really scores. And CTMR, CMR also, they have their own plus points. When it comes to the pericardial thickness, echo doesn't do so well. So this is because of the thickness is not really, the resolution is not so really great. So this is where it sort of comes down, and that's where the CT and CMR really scores. And when it comes down to the cardiac function, you see that the septal motion and the respiratory variations are really good as far as echo is concerned. I think this is where the focus should be when we are looking at constriction. So that should be the one here. Now, when it comes to recommendations, it is fairly high up. So it is around 1C here in terms of pericardial diseases. Now, because of the limited time, so I'm going to focus only on the chronic pericarditis. So this is defined as something which is lasting for more than 3 months. And just a brief sort of, highlights of what this constriction is about. So there are these sort of broadly, they have been sort of looked at in 3 phases. So you have this initial phase where there's inflammation and there is outpouring of the fluid. So there is pericardial effusion. Then after a period, the pericardium goes into the second phase where you have this, the pericardial effusion starts to come down. But now what happens is that the pericardial wall starts to become a little thick. It becomes inflamed. It is edematous and it loses its compliance. And that's when the constriction starts. And then you have this third phase where many of the patients do fairly well, maybe spontaneously they revert, or maybe it is because of drugs. You have the resolution of the inflammation and they normalize. So you have this fibroelastic form as long as that elasticity of the pericardium is maintained. So you know that it is going to regain its elasticity, and then the constriction is going to go away. So you have the transient part of it, and then you have mild constriction in these patients. But once it goes into the fibrocalcific form, that is when it becomes irreversible, and that is where the chronic constrictive pericarditis continues, and then it becomes quite severe. So this is a picture sort of which tells you everything. Just one look at it and you see this very thick sort of stiff pericardium encasing the whole heart, and then you know that the chambers cannot really sort of expand, and then you have the septum in the middle which has to do a lot of work trying to accommodate here. And I'll just sort of go by a few important parameters which have been sort of coming, which have been relooked. And then this is just to sort of what would be the first approach. So we know that the Patterson long axis is the first one which we are going to hit. And we are going to look at the septal shift. So this is a respirophasic entity. And you have the inspiration, expiration here. And then it's a very important parameter here, and you can look at the sensitivity. It is quite high. So compared to all other parameters, this is the number 1 on the list where we look at this respirophasic, and this going towards the LV during inspiration and then goes back towards the RV during expiration. So this is something we should be looking at. And then we have the horizontal sweep also, which you should reduce. Now, this whole sort of, the pathophysiology is sort of it is called as a ventricular interdependence. So you have the filling where of the LV, one ventricle sort of fills up at the expense of the other. So it keeps adjusting back and forth, and the septum goes back and forth like this. Now, this is just again, a frozen frame here. So you can see that you can actually get this in most of your patients, and you can understand how the flow actually happens. So it's sort of, where the RV is sort of expanding here and the LV is less. And then again, during expiration, the septum shifts towards the right side and the LV expands. Next is looking at again, we are sticking to M mode, and we are looking at a different entity. So there have been these terms which have been sort of loosely sort of used. So it is the septal bounce or the septal shudder. So this is more of a beat to beat variation. So it is seen it's not respirophasic. So we have these beat to beat variations where you have this paradoxical movement which happens because of the different filling times. which are happening, and that is those notchings you have to be looking into. And also to a lesser extent, you can sort of sometimes, because of the tethering, you can try to sort of find out whether there is diastolic flattening of the posterior wall. And if you want to put everything together, you can combine it, and then these are really gross patients. These are very obvious patients which you can sort of even eyeball it, and the moment you see it, you know that you're dealing with constriction. So it has a combination of both septal shift as well as the septal shudder, and typically the long axis, short axis, and the four chambers are the ones which give you this information. Next is looking at the pericardial thickness. Of course, we are going to reduce the gain, and then we are going to sort of look at this highly reflective structure. So if it is there, great. If it is not there, it doesn't mean that we are going to be dependent on it. And the cutoff here is again around 3 to 5 millimeters. Then the other important point where we sort of focus upon, as I mentioned in the earlier one, the table which I showed, is the respiratory variation. So this is the second important point. So here we are looking at both the tricuspid and mitral inflow, and typically what happens is you have an E which is very tall and A which is less, and then there's a steep deceleration as the flow goes into the ventricles, and then it is cut off as it hits the non-compliant pericardium, and then it comes back. So you have this typical classic inflow which is there on both sides. Next, you're going to look at the respiratory variations. So the respiratory variations on the right side is slightly higher because of other conditions also can happen. So you have this cutoff of 40%, and then again you have to slow down the sweep, and then you put this respirometer. Most of the machines do have the respirometers, and if you do have it, so it can be very helpful. So use it as much as you can. Next, looking at the mitral side, the respiratory variations. So this is an important point which is in the sort of algorithm, if I have to say so. So where the sensitivity is still sort of great, and this should be used. And the number here is around 14.6. So 15 is the cutoff. Literature also says 25%. So I think anything more than 15, and if there's a clinical correlation, you should use it as much as possible. And then that is the calculation for which you can get your percentage of respiratory variation. Then tissue Doppler. So now moving on from blood Doppler, now we go to the tissue Doppler. So the sensitivity here is 83%. And then here again, a high E prime velocity tells you usually the cutoff is somewhere around 8-9 centimeters per second. Typically sort of, one more point in favor of constriction here. Then you want to, this is this well-known entity, what is called as the annulus reversus. So you're looking at both the velocities on the septum as well as the lateral wall. So normally we see the lateral velocities, that is the E prime, which is higher. And here in constriction, what happens is the E prime velocity on the lateral side is less, and the septum is more, and this is called as the annulus reversus. And then the sensitivity here is around 75%, and then you have this fourth point here. And there is other entity is this annulus paradoxus. So when you have a elevated filling pressure, you would expect to see it, but because of the high E prime velocities, you don't get it. So you get to see a normal sort of E by E prime here. Then you're coming down to the subcostal. You're looking at the IVC now. So again, the IVC will be dilated. It will be non-collapsing, and the hepatic veins. So this is the typical what is called as IVC plethora. So very important point here is to look at the hepatic vein here. So here the sensitivity is 76, and what you see here is the exaggerated sort of expiratory flow reversal that is happening, and this is when the filling is happening through the pulmonary veins or on the veins on the other side, and it keeps sort of going up at every expiration. So this again you can see it, and then there is this ratio also. So this is the forward flow and then the reversal. So if you combine it, and then you get this ratio, if it is more than 0.79, so that means that this is again a point in favor. So when you put all this together, so you have the this table which is sort of very sort of, it looks very nice when you, and you can use this as a sort of a workflow to identify these patients. So the main important sort of the findings are the ventricular septal shift. You have the medial E prime velocity, and then you have the hepatic vein also. And then you look at this sensitivity, it starts to come down here, and the positive predictive value starts to go up here. And when you start to combine these parameters, so you get to see that the positive predictive value really sort of climbs when you have this 1 with 3 and 5. So this is how you can sort of integrate these findings and come to a conclusion. Then there is the strain also, and this is a parameter which can also be looked at whether they are improving. You can monitor them. So here again, when you have the reversal of the strain, it is called a strain reverses here. And this is a table which is available in literature quite extensively, how to differentiate between restrictive tamponade and then the constriction. So we'll not go much into this. So just primarily, these are the constrictive features. And then you know that the restriction is primarily a muscle issue. So you have these low velocities over there. And tamponade, you have the fluid. So that's where the differentiation can be done. And then with this present day, if I have to call this as a state-of-the-art approach, we have to be more integrated so that we can deliver better, faster in terms of diagnosis. So you can have this other additional imaging modalities, use it as much as possible, and come to a conclusion combining both CT and MRI. Thank you.